Hi, my name is Judith Kelley. I work in an acute care setting, and I'm here to talk about Intertrigo and the challenges of that in the acute care setting. Next slide. The definition of Intertrigo has been talked about several times throughout this presentation. As we know, it is moisture-associated skin damage where there is both moisture and friction causing the irritation to the skin. Many patients in the intensive care unit suffer from this, and we don't chart on that, and I believe that's why we don't have the incidence and prevalence that we would like to see. It is not identified, it is just treated. The bedside nurse treats the Intertrigo in the hopes of reducing any skin breakdown. Next. Again, the causes of moisture vary. Certainly we know that obesity, immobility, diabetes, hot and humid conditions, and incontinence all play a part in moisture-associated skin damage. But there are a few I would like to talk about in particular, and that is patients with either heart, liver, or respiratory failure. They all have fluid overload. They all have generalized weeping edema, and how do we treat that? Again, in the hospital setting, this is a very difficult issue. We have difficulty interning the patients when they have these conditions. Doctors often write orders that patients cannot be moved. Again, moisture lays trapped, and that is not a good issue for us. Next. Identifying Intertrigo is very difficult for the bedside nurse. She will treat the moisture, she will treat the skin, but actually labeling it as Intertrigo becomes very difficult. She doesn't want to make a mistake, and with all the pressure being put on staff about charting accurately for pressure ulcers, they will often call Intertrigo pressure. Now, we understand that you can get a pressure ulcer that started as Intertrigo if it has not been treated and if it has become a bigger issue for the patient. And how do we do that? It will become mixed etiology. It will start as moisture, end up as pressure, and then full thickness. Next. How do we treat? We want to manage the moisture. We do not want to hide the moisture. We do not want to contain the moisture. We do not want to pretend it's not there. Nurses are excellent at making labor-intensive things to contain moisture. Unfortunately, when that labor-intensive process is taken off and all of the wet gauze has laid against the skin, we now have a case of Intertrigo, moisture-associated skin damage. It is the culture we are trying to change in the hospital, and we find that by using Interdry, it is a much easier fix. You can take a piece, cut it, wrap it around the arm, wrap it around the leg, wrap it around the scrotum that is engorged and swollen, and it becomes an issue of changing the culture of how the nurses think about that. So having it at the bedside, having it where the nurses can get it without a doctor's order, where the nursing assistant can get it, and having it changed on a PRN basis. Look at it. If it needs to be changed, change it. It has become far more effective than the labor-intensive process we have been doing in the past. Again, the nurses need to know that they can do that without a doctor's order. So in the hospital, we have put it in our clean utility where they can go and get it whenever they feel the need for it. If you have any questions, please feel free to pass those on to Lisa or Lena, and they will get those questions to me, and I'll be happy to answer that. Thank you.